All right, so it is my distinct honor and privilege to introduce our next speaker. Dr. Tobias Eckle is a professor of anesthesiology at the University of Colorado Anschutz Medical Campus in Aurora. He earned his MD, PhD from the Eberhard Karls University in Tübingen, Germany. Apologize for my German. He's a board-certified anesthesiologist in Germany and the United States. His research work has been funded by the National Heart, Lung, Blood Institute, American Heart Association, Foundation for Anesthesia Education and Research. He's authored over 80 peer-reviewed publications, H-index 40, over 1,000 citations. He's currently the Director of Grand Rounds, Medical Director of Advanced Practice Providers, and Associate Vice Chair of Faculty Development in the Department of Anesthesiology at CU. And I have a little gift for him on behalf of CSC for your work in translational chronobiology.
Oh, wow.
Congratulations.
Thank you so much. Thank you. So honored. Thank you. I guess I'll just put this up here. Doesn't matter. And this inside. All right, let me know if you can hear me. I'm normally a loud person. Hopefully I don't break any ears today. Thank you for this. It's a great honor. Thank you, Tammy, for inviting me. It's a great pleasure. I'm really excited to present today. I'd like to start with the sun. That's the only way I can look at circadian rhythms. The rest I don't fully understand, but that makes sense to me, in particular from where I come from. Evolution really explains to me how circadian rhythms works. And you probably can appreciate that the sun is the center of circadian rhythms. The sun regulates the circadian rhythms. And when Earth evolved, the sun was already there, but eventually there were these green algae that started making oxygen. And they made so much oxygen that they completely changed the environment we live in. So you know that today we have 20% oxygen, and if you look at this picture, you can see and realize, hopefully, these two factors really dominate all organisms on this planet. And you can also imagine that based on these critical environmental factors, that all organisms have to adapt to these factors, right? That we have to develop molecular mechanisms that can sense light or oxygen. And indeed, you know, in a clinical setting, somebody is oxygen deprived, you give them oxygen, but barely you can see a physician walk around and say, hey, this patient, hey, he needs more light. Let's give him some light therapy. Indeed, not only evolution gives you really a clue how things work, but if you have a closer look at the molecular mechanism, you really see that these pathways have evolved, and there's a connection between these light sensing pathways, or circadian rhythms, how you call it, and the oxygen sensing pathways. And I don't want to talk about how the circadian rhythms works. You know that light shines through the eyes, there's a signal through the suprachiasmatic nucleus, all these proteins are regulated. However, what is really fascinating that there's a link between those light sensing pathways and these oxygen sensing pathways. And in fact, John Hogenish was probably one of the first finding this connection with HIF-1 alpha and the circadian rhythm proteins. He just didn't call it HIF-1 alpha, it was MOP1 when he sequenced it. And what they have in common is this PAS domain. And this PAS domain combines those proteins, and the PAS domain is believed to be able either directly or indirectly allow those proteins to sense oxygen or light. So now if you think a little bit outside of the box, you can imagine, well, with light you can activate those circadian rhythm pathways, but maybe with light you also can activate those HIF pathways and help an organ that is oxygen deprived to survive these conditions of low oxygen availability, what you have during a heart attack, lung injury, or sepsis. And indeed, that's what we did over the last 14 years. I started working in the field of adenosine signaling and cardioprotection, so I actually was more focused on the ischemic mechanism of ischemic preconditioning. However, I eventually realized that period 2 was an important cardioprotective factor, and since period 2 is light regulated, somebody from Harvard said, hey, why don't you expose animals to intense light? That's going to help you. And I thought it was a stupid idea, but I did it regardless. And so what I found eventually was that indeed, even with short light exposure times, you could lower troponin levels. This was abolished in period 2 knockout animals We eventually started housing animals under intense light conditions, meaning that we replaced just the ambient light with an intense light box. This is a light dark cycle of 14 and 10 hours, and you can hopefully appreciate that over the course of a week, infarcts become smaller, and if you look at the cycling of period 2, using a luciferase mouse, there's increased period 2 cycling amplitude enhancement. You can reproduce the same if you look at wheel running, and hopefully you can see that intense light again increases the amplitude of those animals in intense light housing. However, this was abolished in PER2 knockout mice. And based on what I just showed you, of course, we were curious, could light actually induce these hypoxia pathways under normoxic conditions that were housing animals on intense light? And we did an array, a big whole genome array, looking at period 2 and intense light regulated genes. And the top gene was angiopoietin-like 4, which is actually something that has been shown to protect the endothelial barrier during ischemia and reperfusion injury in mice. And so first we looked at HIF-1α binding in general, and indeed could show that if you housed animals under intense light conditions, that HIF-1α binding to those hypoxia response elements in the promoter region of genes that are HIF-1α regulated increases with intense light housing, and even more, we also were able to be more specific and show that HIF-1α binding to the HRE region in the promoter region of angiopoietin-like 4 was enhanced by intense light housing. And of course, here the functional studies, we also could eventually prove and show that intense light was able to reduce the endothelial dysfunction, barrier dysfunction during reperfusion injury by reducing the leakage of Evans blue into the interstitial space. And eventually we also could show that this was endothelial PER2 specific by using tissue-specific mice. Okay, 14 years, very condensed. But I wanted to show you something completely different because I rarely talk about this. More something what you eventually could do in a clinical setting, right? I remember, I think 10 years ago, I was in a meeting with John Hogedish at the NIH, and the only thing the NIH was talking about was, well, we understand circadian rhythms are important, but how do we use it? How do we do therapy? And I think that's where we still lack a lot. We know a lot of a mechanism, but treatment is a little bit behind. So we always did that at the same time when we did all these animal experiments. We started early on exposing ourselves to intense light in the morning for several days, collecting buccal tissue samples, blood samples, and eventually we were able to reproduce that also in buccal samples. We could increase period 2 levels in the morning, in the evening as well, that eventually also this resembled something like a circadian amplitude enhancement. We were able to show that this intense light in particular was efficient to suppress melatonin levels. There's something very interesting figure here. On the left, the white bar is the melatonin levels when we came into the research lab in the dark. However, the gray bar is, these are people who actually woke up in the research lab, and you have to imagine Denver, you have big windows and there's still a lot of light there. We have roughly 300 sunny days a year, not this year, but normally we do. You can see only the intense light box, in fact, was really able to significantly suppress those melatonin levels. And I always tell people that's probably why most of the time we'll walk around like foggy monsters and being not really awake and alert during the day, because that dip never happened. We also looked at other parameters. We did look at triglycerides because they were sort of a biomarker for endothelial dysfunction. You can see those triglycerides were significantly reduced with intense light therapy. We also did metabolomics. This is a mass spectrometry analysis where when we then used those peaks and compared them to a library with well-characterized metabolites, and we could see that intense light mainly affected metabolic pathways, glycolysis, TCA cycle, but also other metabolic pathways. And last but not least, we also could show that this intense light therapy was able to improve your sleep behavior, increase sleep quality, for example, by reducing the wake-up periods after the sleep onset. But also, if you look at activity levels, you could see that also with this analysis using actigraphy, you could show that intense light increased the circadian amplitude. And I keep saying this because I think that's probably a key how we want to approach patients in the future in a clinical setting. We didn't stop here. We also looked at protein in plasma samples using the SOMA scan. The SOMA scan was once method of the year. Nature methods supposed to be a very specific and sensitive protein array. Probably one most comprehensive protein analysis on the market these days, and you can catch up to 1,300 proteins. I think it's a bit more right now. In plasma samples. We did this, and in fact we could show that intense light indeed is able to regulate significantly up to 63 proteins. Of course, there are more proteins, but that's what that assay can deliver. And we're quite surprised though when we looked at the data, because it indicated when we did the Ingenuity pathway analysis that intense light is dominantly anti-inflammatory by inhibiting cytokines that attract neutrophils. And with that knowledge, I actually went back into the lab, and in this case, we used a mouse model for hemorrhagic shock lung to see if that is really true, if light could be anti-inflammatory. And how you do such a model is you remove blood until the blood pressure basically drops to a level which is quite unhealthy. You can see that that's a mean blood pressure below 50. Most organs are not perfused anymore. At some point after 90 minutes, you give blood back. You have a severe ischemia reperfusion injury of the whole body, and normally that hits the lung first. It's a severe inflammatory reaction to the lung. And it's interesting, when we looked at the hemodynamics, we were quite impressed because you might be able to appreciate that those animals that were housed in intense light conditions had significantly better hemodynamics towards the end of this recovery period. And we also looked at inflammatory markers in the bronchoalveolar lavage, and hopefully also you can see this is really dramatic effects. You can see IL-6 and IL-8 in these lavages were at baseline like sham-operated animals. And even if you looked at the barrier dysfunction that happens during acute lung injury, where you destroy the endothelial and epithelial barrier, there was barely any leakage of albumin or protein into the BAL of those animals. Another very important pathway we found with light was when we looked further, did this volcanoplot analysis, we realized that intense light in fact inhibited a lot of proteins that actually promote clotting, blood clotting. In particular, platelet factor 4, which is normally something that helps to activate those platelets. And what we did, we simply exposed ourselves to light and studied blood clotting. And sure, if you can appreciate that, so there's the activated clotting time on the bottom, and the CR is the clot rate. The clotting rate is actually what comes as a second step, and it's platelet dependent. The activated clotting time is something that is the initial phase. And right after light exposure on the top, you can see both were changed towards less clotting. However, what was more interesting is after 5 days, while the ACT, which is the initial phase, has returned to baseline, the clot rate was still significantly reduced to compared to day 1. So indicating that there's really a permanent effect of intense light on the clotting events in a human system. Then hopefully we still have some time. I want to quickly talk about chronopharmacotherapy, something we had looked at in particular in my field, in the field of anesthesiology. And it's something, you know, this study from John Hoganesh is very important. Somebody asked me yesterday a little bit what I was thinking, because I'm mainly a physician, physician first, then researcher. And I heard about this aspirin study. And I guess John Hoganesh points it out, the problem is probably with pharmacotherapy is that many drugs have such a long half-life time that very often we struggle with these effects, and we might not even see them, and eventually might have to redesign some of the drugs. However, what I show you, nice thing is about this drug has really a short half-life time, and it's something that was a project a medical student in my lab. It's completely random, but I thought we should look at it, why not? And so the idea was, what are doing anesthetics to period 2, right? Period 2 is cardioprotective, why would I not be interested in this? So we looked into this, and it was quite surprising that midazolam, something we use every day, almost every patient worldwide gets midazolam. But what midazolam does, it always significantly downregulates period 2. It doesn't matter what organ you look at, it's always the same. It doesn't matter who does it, it's always the same. Midazolam acts by GABA receptors, and there's a link between GABA signaling and the circadian system, so that makes a lot of sense. Eventually, we took this into our heart model, and indeed, midazolam is detrimental in heart ischemia. Huge infarcts, high troponin levels, terrible. And eventually, we also thought about nobiletin, since we know this is a circadian rhythm enhancer, can eventually increase HER2 levels, and we were able to show that nobiletin can reverse those effects of midazolam, so increasing again our period 2 levels, and even if we went back to our ischemia model, we could show that infarcts, again, smaller if we co-treated with nobiletin, midazolam-treated mice. We also were able to show that nobiletin actually is cardioprotective, and it may be even HER2 specific. We even went a step further because this was something we thought we could patent, but you know how patent people are. They say, well, you don't own nobiletin, Tobias, so forget about it. Get your own molecule, and I started looking at all flavonoids I could buy from Sigma, wherever. And what was quite interesting, though, and so I'll show you this data, is when we compared all those flavonoids, the only two that were cardioprotective were nobiletin and tangeratin. And those people who have known the studies on those small molecules, they will remember those two because those exactly are the circadian rhythm enhancers, and the others are not. But based on these studies, of course, the question came up eventually, well, what happens to all our patients who get midazolam every day? Isn't it terrible? Everybody's getting midazolam, and are we killing them? Are we causing heart attacks? Nobody knows, right? Probably not. When I started research, like 1997, somebody once told me, things that are significant eventually are found. So probably it's not too significant. Still, I think it was worth looking into it. So what we did, we looked into a large database. This is the MPOC database. It's located in Michigan. They collect all electronic data, all the electronic records from anesthesiologists in this nation since many, many years. And so we could collect data from patients across 50 institutions between 2014 and 2019, and like over almost 2 million cases, and half of them received midazolam. And when we did the analysis initially, we didn't see any, so what we looked at was something that's called MINS. MINS is called myocardial injury after non-cardiac surgery, something that was discovered a few years back. And it's interesting, it's something that's only characterized by a troponin increase, that's it. Just troponin, so no classical signs of heart attack. It's just an increase of troponin. However, what is interesting about this MINS is the higher your troponin levels are, if you have surgery, the higher your likelihood that you will die within the next 12 months. So significantly associated with mortality. So it is an interesting phenomenon. We just don't know what to do, what to do against it or reduce it. So what we found was there was, in the overall population, midazolam doesn't seem to kill people. So that's the good news. So don't be stressed if you go seeing an anesthesiologist giving you midazolam. However, when we looked at differences between night and day, there was a really significant difference. And I'm not sure if you can see this in the bottom. These are the odds ratios for MINS occurrence. So if you had daytime surgery, actually, the odds ratio was below 1. But during the night when you received midazolam, the odds ratio was 3.5, indicating that the risk for having a myocardial injury at night when you receive midazolam and having surgery might be significantly higher than if you have this during the day, meaning you might not want to give midazolam during the night. And minus minutes? Minus minutes. This is just something we published this week. Just wanted to show you this because that's, I think, is something that should probably be transferred into the clinical setting. A combination of all of these principles we have learned from the circadian field, using chronopharmacotherapy, but also using all these elements like light, exercise, restricted feeding, and so on, to eventually increase the circadian amplitude, enhance the circadian amplitude. And I mean, it probably doesn't matter if you have had a heart attack, if you're critical care, or if you're just a regular person at home. I would assume, I'm just convinced that this is somehow something that will promote health in all of us. And many thanks to all these postdocs and smart people, particularly John Hogan has really helped me boost my brain in this field because I'm a clear outsider in the field. And thank you so much for your attention.
Tobias, thank you very much. What a great presentation.
Thank you so much. You're so nice.
I really like the last part, but I'm curious, because a lot of the benzodiazepines react, you know, they're different half-lives and different on-off rates and the receptor, but effectively, they do the same thing. Most people will take their Valium or you know, some sort of lorazepam for travel or other ways at night. And I'm wondering, this is interesting that you think that would cause more of a cardiac burden from my assessment. And these are thousands and thousands of prescriptions are written daily for these drugs. So what is your comment about the fact, I'm just curious, you know, individuals taking this, they can't sleep or they're nervous, they take a benzodiazepine.
I know. Well, I don't know. I cannot answer that question, right? We would need a prospective trial to prove that concept, right? I have to admit, this is the weakness of all those data. These are retrospective. It's still large, but you know, you can get things significant that are not real. But it's a fair point, right? I can tell you, and I would just recommend people not taking those drugs just because they have sleep disorders. Maybe you should exercise instead. Right? Or meditate if they're anxious.
We can talk about it after. There's some other questions. Thank you.
Yes.
Thank you. Great talk. I was fascinated, and I love the clinical application of a nurse. And you know, it really speaks to one of the findings that sort of came about just by reflection, and these were comments by my ICU nursing colleagues, and that was that they thought that the people that were sitting or in beds on the side of the building with windows did consistently better. Their outcomes were consistently better. And it was kind of, you know, poo-pooed or whatever, and I'm going, oh no, there's probably something, you know, to this effect with the light. And so this is really wonderful. You know, it speaks to maybe we need to do some changes in our architectural designs in terms of our hospitals. But it was that natural light that I think supported that circadian rhythmicity. And it really is this wonderful blending of architecture and healthcare that this kind of research supports. So thank you, and we should always listen to the hunches or observations of our clinical colleagues.
Thank you. And I didn't show those pictures though, right? But you know, many institutions in Europe have remodeled their
Yes,
ICUs.
some have.
Munich more recently, with the help of some circadian researchers, Berlin a few years back. And yeah, I don't know, the United States lacks a little bit. I think money is always an issue here.
Thank you.
So maybe we can continue the discussion after
Yeah.
in order to prevent any. Thank you
Thank
so
you,
much.
thank you.
Thank you.